My name is Ailsa and I'm a chronic kidney disease educator. So not only do I provide education to patients who are diagnosed with kidney disease, I continue to look after them if they've chosen a non-dialysis pathway in the renal supportive care space. So the treatment options that we explore with patients, we generally talk about dialysis, both home hemodialysis and peritoneal dialysis, which is another home therapy, and then we compare that with in-centre dialysis. We also talk about transplantation, and then we also offer a renal supportive care pathway, which we sometimes refer to as a non-dialysis pathway for these patients. Sometimes, it has many names, conservative care or renal supportive care. We tend to use a renal supportive care terminology when we discuss it. The patients receive the same care regardless of the treatment option they decide on. The supportive care pathway it's a pathway for patients that have chosen not to have dialysis. So the way I explain it to patients is we have a real focus on symptom management and improving quality of life through the management of symptoms that these patients experience. Our goal is still slowing progression of their kidney disease. And when we talk about slowing progression, we make sure that patients are on the right combination of blood pressure medications, medications that are renal protective. There's not a magic pill that these patients can take that is going to make their kidney disease improve. It's really around slowing progression. That's part of our medication management in the renal supportive care pathway. I think giving patients as much information, it certainly aids in their ability to make a decision. And I almost paint a scenario for the patient of this will be your routine. So this is what coming into a dialysis unit 3 times a week will look like for you. Factor in how far away they live from the dialysis unit, what's their mobility, do they use a walking frame, are they independent with getting up, getting dressed, do they need help with that? Are they going to be able to transport themselves to and from dialysis? And then sort of what impact will that have spending 3 days a week away from home if they've already identified the most important thing for them is to be at home with friends and family, spend time with their wife or whoever it may be? How do they feel about having to spend 3 days a week away from them, and getting them to think about that, what the future might look like for them? I think that's really important, and then contrasting it with a renal supportive care pathway. So what that might look like for the patient is really important in their decision making. I actually ask during my meetings, what's the most important activity in their life? Recently, I met with a patient who enjoyed going for coffee every day with her friendship group. She was 79 years of age. She said, I don't want to stop doing that. I don't want to go to dialysis 3 times a week. It would mean I wouldn't be able to catch up with my friends every day and have my morning coffee. And I usually ask patients what they want to get out of choosing a dialysis pathway, because we know that patients over the age of 75 and particularly over the age of 80 doesn't improve their life expectancy a great deal. And so when patients say that they want to live longer, we can almost guarantee an 83-year-old patient, for example, that they're potentially not going to live any longer. And that's a very individual response, but it really determines their decision making with which treatment option they might want. So we ask them what's their most important activity, because sometimes they're unable to do that if they were to attend a dialysis unit 3 times a week. At that point, when we talk about not undertaking dialysis, I've found in the past, because I've been doing this job for a little while, that patients become fearful that they'll be discharged from the service and not looked after if they choose a non-dialysis pathway. So I immediately reassure them that if they choose a non-dialysis pathway, they are still very much looked after. They still attend our clinics just as they are now. They still have their bloods for review. Our focus is more on how patients are doing, whether they're still managing to live the life that they want to live, and managing symptoms as they arise and slowing progressions. Even from initial education with patients, we encourage family members or close friends, whoever is going to be involved in this patient's care, we encourage their involvement in the discussions, not necessarily to convince or provide their point of view, but to be aware of what the patient has decided and their reasoning behind it, I think makes a real difference. So for patients, if their family members have been involved in the discussions around treatment pathways and choosing renal supportive care pathway and their reasoning behind that, they're usually really supportive. Yeah, they because they understand why they may have chosen that pathway. The renal supportive care pathway, patients have a designated nurse that they can get in contact with, and if they have questions that need our kidney specialist input, I can communicate with them, and we certainly organise our appointments for our patients in the renal supportive care service and their follow-up. It allows probably for more frequent contact if the patient wants it. We're really guided by what the patient wants to do. And if they say, coming to the clinic, it's a little bit hard for me, could I have a phone consult or a video consult for this next one, then we're really agreeable to making it work for the patient. We do consult with GPs, we work really closely, but we work with other services as well. So sometimes we refer to places such as community physiotherapy or the Falls Clinic. We consult with pharmacies. Our social worker is actively involved in those clinics. There's always a nurse in attendance during the clinic appointments. But yeah, we do work closely with the GP. So after every visit, there's correspondence sent back to the general practice as well with the outcome of that clinic visit.